Noradrenergic neurons are an important target for drug action. In this lecture, we describe the function of noradrenergic neurons, properties of adrenoreceptor, and discuss the various classes of drugs that affect them. You should revise anatomy of sympathetic nervous system and the effect mediated by sympathetic neurons. Remember, most postganglionic sympathetic neurons are adrenergic. In another word, their neurotransmission are noradrenaline. You should be well aware of the effect of sympathetic activity, especially on smooth muscles and cardiovascular system. The receptor sites for noradrenaline are located over the entire surface of effector cells. Noradrenaline not only released from nerve terminal but also from varicosities. Each varicosite acts like a nerve terminal. Adrenoreceptors are classified into alpha and beta adrenoreceptor. Main pharmacological classification into alpha and beta subtypes based on order of potency of agonist as well as selective antagonist. There are two main alpha receptor subtypes, alpha 1 and alpha 2, each divided into three further subtypes. Similarly, there are at least three beta adrenoreceptor subtype, beta 1, beta 2, and beta 3. All belong to superfamily of G protein coupled receptors. Alpha 1 receptors activate phospholipase C, producing inositol triphosphate and diacylglycerol as a second messenger. Inositol triphosphate releases calcium from intracellular stores, and calcium causes contraction of smooth muscle as in blood vessel. All types of beta receptors stimulate adrenal cycles. Increase in cyclic AMP concentration would increase the heart rate. However, it will cause relaxation of smooth muscle. On the other hand, alpha 2 adrenoreceptor inhibit adenylate cyclase, decrease in cyclic AMP formation. Adrenaline or epinephrine secreted by chromaffin cell from adrenal medulla. Adrenaline would have access to all alpha and beta receptors through bloodstream. The main effect of adrenoreceptor activation by adrenaline are as follows. It causes bronchodilation, increase cardiac rate and force, increase skeletal muscle contraction efficiency, and cause muscle tremor. It causes lipolysis. Adrenaline causes relaxation of gastrointestinal smooth muscle, and on the liver it causes glycogenolysis. And some other central nervous system effect, including mental alertness. Pheochromocytoma. Pheochromocytoma is a tumor of adrenal gland, often cause adrenal gland to secrete too much hormones. It can lead to high blood pressure and tachycardia, cause headache and sweating, and induce anxiety and panic disorder and some other symptoms. Surgical removal of the gland is the curative option. However, drugs are used for pre-operative management of pheochromocytoma. The process of noradrenergic transmission is basically similar at all sites in the body. Synthesis of noradrenaline takes place at nerve terminal and varicosities. The starting material in noradrenaline biosynthesis is tyrosine. Tyrosine is taken up from bloodstream by noradrenergic neuron. Within the neuronal cytoplasm, tyrosine is converted to DOPA or L-DOPA, or sometimes called levodopa, by enzyme called tyrosine hydroxylase. L-DOPA then is converted to dopamine by DOPA decarboxylase in the cytosol. Dopamine then is actively transported into the vesicle. Within the vesicle, dopamine is converted to noradrenaline by enzyme called dopamine beta hydroxylase. Noradrenaline release occurs by calcium-mediated exocytosis from varicosities. Noradrenaline interacts with its receptors within the synaptic cleft. Noradrenaline action is terminated mainly by transported mediated reuptake pump called uptake 1. The majority of noradrenaline entering the neuron is transported back into the vesicle. This is a monoamine pump that transports both dopamine and noradrenaline. A small proportion of noradrenaline entering the cytoplasm is metabolized by enzyme monoamine oxidase located in the mitochondria. Monoamine oxidase also found in the effector cells. Although less important than uptake 1, but there is an uptake system which transport noradrenaline into effector cells, where it metabolized by monoamine oxidase and another enzyme called catechol or methyl transferase, sometimes called uptake 2 system. Catechol or methyl transferase is also found in the liver. Hepatic monoamine oxidase and catechol or methyl transferase are responsible for metabolism of adrenaline and noradrenaline circulating in the blood. At all these stages of synthesis, storage, release, metabolism, as well as receptor size, uptake system, drugs interference is possible. This figure illustrates biosynthesis of noradrenaline and adrenaline, and I explained in previous slide. The adrenal medulla possesses an additional enzyme for converting noradrenaline into adrenaline. It's called phenylethanolamine and methyl transferase. The adrenal medulla is innervated by preganglionic cholinergic neurons. Nicotinic receptor activation causes release of adrenaline into the bloodstream. The released adrenaline can activate alpha and beta adrenaline receptor at all sites in the body. Another point I should make in this slide, dopamine is a neurotransmitter in central nervous system. They call dopaminergic neurons. Many drugs which impair adrenergic transmission may also have a similar effect on dopaminergic neurons. Metyrosine, also called alpha-methyltyrosine, inhibit tyrosine hydroxylase and reduce noradrenaline and adrenaline synthesis. Metyrosine is useful in pheochromocytoma, both perioperatively or as a long-term therapy in operable cases. Carbidopa and benzarazide are inhibitors of dopa decarboxylase. These drugs are relatively large hydrophilic molecules and do not enter brain. Therefore, only inhibit peripherally located dopa decarboxylase. L-dopa or levodopa is a drug of choice in medical treatment of Parkinson's disease. Combination of levodopa with carbidopa or benzarazide significantly reduce the dosage of levodopa needed in Parkinson's disease, and therefore peripheral adverse effect of levodopa is reduced. In summary, carbidopa or benzarazide block dopa decarboxylase and is used in treatment of Parkinson's disease. They have not much effect on synthesis of noradrenaline on noradrenergic neuron. As you know, in the striatum, which is part of the brain center for control of movement, there is a functional balance between acetylcholine and dopamine. In Parkinson's disease, there is a shortage of dopamine in the striatum. This imbalance can be restored by giving levodopa, the precursor of dopamine. In the striatum, levodopa is converted to dopamine. Of course, you will receive more details on central nervous system pharmacology lecture. Methyl dopa is a substrate for dopa decarboxylase and is converted to alpha methyl dopamine. It competes with dopamine for transport into the vesicle. Dopamine beta hydroxylase then oxidize alpha methyl dopamine to yield alpha methyl noradrenaline. Alpha methyl noradrenaline is stored in the vesicle and can function as a false transmitter. Therefore, on arrival of action potential, instead of noradrenaline, alpha methyl noradrenaline is released. Alpha methyl noradrenaline has similar potency with noradrenaline on evoking postsynaptic receptors. However, on perisynaptic alpha-2 adrenergic receptor, alpha methyl noradrenaline is more potent than noradrenaline. If you remember, presynaptic alpha-2 autoreceptors exert a negative feedback, inhibiting neurotransmitter release. Methyl dopa is useful in treatment of hypertension in patients with asthma, especially those patients that cannot take beta blocker, and in pregnancy. It is relatively safer. Methyl dopa has similar effect on the central nervous system adrenergic neuron, which controls blood pressure. The brainstem vasomotor center controls the discharge of neurons innervating blood vessels. Reserpine and another drug, tetrabenazine, inhibit carrier-mediated noradrenaline accumulation in vesicle. Since dopamine uptake is inhibited, noradrenaline synthesis is also impaired. Therefore, noradrenergic neurons' activity is reduced. These drugs also affect chromaffin cells of the adrenal medulla and central adrenergic, dopaminergic, and tryptophanergic neurons. Reserpine in past was used for treatment of hypertension. However, it can induce severe suicidal depression and therefore no longer has any clinical use. It is only used as a research tool. Part of hypotension action of reserpine is impairment of adrenergic transmission in vasoactive motor center in central nervous system. Tetrabenazine is used for treatment of Huntington's chorea, a disease of movement associated with excessive dopamine, presumably because tetrabenazine depletes central dopaminergic neurons. Noradrenergic neuron blocking drugs like guanethidine and bethanyidine are selectively concentrated in adrenergic neurons via uptake 1 transporter. They block transmitter release partly by their local anesthetic action. Guanethidine is effective in treatment of severe hypertension but cause side effects including postural hypotension, diarrhea, and nasal congestion. Guanethidine eye drop can lower intraocular pressure in chronic glaucoma and can reduce the exophthalmos and eyelid retraction of hyperthyroidism. Tricyclic antidepressive drug and cocaine are inhibitor of uptake 1 transporter system. Sympathetic effects are enhanced by such drugs. The antidepressant action of tricyclic antidepressant agents like imipramine, amitriptyline, nortriptyline has been attributed to their blockage of noradrenaline uptake in the central nervous system. Drugs which reduce noradrenergic neurons' activity cause depression. For example, methyldopa, reserpine, tetrabenazine. Drugs which enhance adrenergic activity, they are useful in treatment of depression. Therefore, there is a hypothesis which suggests that in depression there is a lack of monoamine, including noradrenaline. You will receive more details in pharmacology of antidepressant drugs. Cocaine inhibits the noradrenaline uptake process at concentration less than those required to produce local anesthesia. Its misuse is due to its stimulatory effect on central nervous system. Enzyme degradation is not important mechanism for inactivation of noradrenaline into junctional cleft. It is largely inactivated by neuronal uptake. Adrenaline release from adrenal medulla are inactivated by enzyme destruction. Circulatory amine, noradrenaline, adrenaline, dopamine, and possibly dietary amine are metabolized by the enzyme catechol O-methyl transferase or by monoamine oxidase or both enzymes. The major product of biotransformation of noradrenaline and adrenaline is vanillyl mandelic acid (VMA). The urinary extraction of vanillyl mandelic acid is raised in pheochromocytoma. Vanillyl mandelic acid concentration in collected 24 hours urine can be used as a diagnostic test for diagnosis of pheochromocytoma. Monoamine oxidase is found in the intestine, in the liver, and in mitochondria of noradrenergic neuron. Phenelzine is non-competitive inhibitor of monoamine oxidase, while tranylcypromine is compatible, is a competitive inhibitor. Monoamine oxidase inhibitors have place in the treatment of depression but are limited usefulness because of their drug interaction. They may also inhibit mixed function oxidase, which is an important enzyme in drug metabolism in the liver. In addition, they have interaction with dietary tyramine. Significant amount of tyramine is found in cheese, beef extract, yeast extract, and also some alcoholic drinks. In patients under treatment with monoamine oxidase inhibitors like phenelzine, tyramine, tranylcypromine, tyramine in foodstuff can cause dangerous hypertensive crisis. Therefore, you should tell your patient that do not consume tyramine-rich foodstuff like cheese. Monoamine oxidase is composed of several isoenzymes, the most abundant of which are called monoamine oxidase A and monoamine oxidase B. Both types are found in most peripheral noradrenergic neurons, but liver and gut mucosa contain mainly monoamine oxidase A. More interesting, part of the brain, including striatum, contain mainly monoamine oxidase B. Phenelzine and tranylcypromine are non-selective inhibitors of monoamine oxidase. They inhibit both monoamine oxidase A and monoamine oxidase B. Moclobemide is selective inhibitor of monoamine oxidase A. It has a reversible and short-acting effect. Moclobemide is used for treatment of depression. Cheese reaction is less severe with moclobemide. Siligelin is a selective inhibitor of monoamine oxidase B. It forms an irreversible complex with the enzyme. Siligelin has no interaction with tyramine. Siligelin is used in adjunct to levodopa for treatment of Parkinson's disease. It allows reduction in dose of levodopa. Entacapone and tolcapone are catechol O-methyl transferase inhibitors. Catechol O-methyl transferase is present in adrenal medulla and many other cells and tissues. Inhibitors of catechol O-methyl transferase is given in combination with levodopa to inhibit degradation of levodopa in Parkinson's patients. Certain chemical agents such as tyramine, amphetamine, ephedrine, and methylphenidate are called indirectly acting sympathomimetics. These drugs act as substrate for noradrenaline uptake and gain access to the neuron. They then transported into the vesicle and displace noradrenaline from the vesicle. Noradrenaline escapes into the synapse via uptake 1 transporter. Amphetamine is an inhibitor of monoamine oxidase. Therefore, high proportion of displaced noradrenaline escape from neuron and activate postjunctional adrenoreceptors. Noradrenaline release evoked by tyramine-like drug does not require the discharge of neuronal action potential. These agents are central nervous system stimulant. Methylphenidate is clinically used for children with attention deficit disorder. (34-dehydroxyphenylethylamine) is called catecholamine. You read a lot about circulating catecholamine in the textbook. Dopamine, noradrenaline, adrenaline, and some drugs such as phenylephrine, isoproterenol. They have catecholamine structure, so they call catecholamine. What you should know is that when you hear about catecholamine, just remember it includes adrenaline, noradrenaline, and dopamine. A slight change in the structure of adrenaline can yield compound which selectively activate either alpha or beta adrenoreceptors. Adrenaline and noradrenaline are both alpha and beta adrenoreceptor agonists. Phenylephrine, compared to adrenaline, it lacks a hydroxy group on the benzene ring. Provided that excessive drug concentration is avoided, phenylephrine activates alpha adrenoreceptors. Isoproterenol, called isopronaline in England, in comparison with adrenaline, it has two extra methyl groups at this site. Increasing the size of substituent on the nitrogen atom increase selectivity for beta adrenoreceptors. As I mentioned, main pharmacological classification into alpha and beta adrenoreceptor subtype based on order of potency among their agonist and antagonist. Relative order of agonist potency for the alpha adrenoreceptors is as follows. Noradrenaline is equal or slightly potent than adrenaline, but far more potent than isoproterenol, so that isoproterenol may regard as inactive at the alpha adrenoreceptor. Relative order of agonist potency for beta adrenoreceptor is as follows. Isoproterenol is more potent than adrenaline, and adrenaline is more potent than noradrenaline. Noradrenaline and adrenaline show relatively little receptor selectivity. However, nowadays we do have selective agonists. For example, phenylephrine and methoxamine are selective alpha-1 adrenoreceptor agonists. At concentration which this drug activates alpha-1 adrenoreceptor, they have no effect on beta adrenoreceptor and little effect on alpha-2 adrenoreceptor. Alpha-methylnoradrenaline and clonidine are selective alpha-2 adrenoreceptor agonists. Selective beta-1 adrenoreceptor agonists include dobutamine and perinaltrol. Selective beta-2 adrenoreceptor agonists include salbutamol, terbutaline, salmeterol, ritodrine, formoterol. Selective beta-3 adrenoreceptor agonist is under development for control of obesity. They are not clinically available yet. Before we go to clinical application of adrenoreceptor agonists, let's describe their location and function on some tissues. First, example of effect mediated by alpha-1 adrenoreceptor. In radial muscle of iris, innervated by sympathetic neurons, the receptor is alpha-1 adrenoreceptor. And alpha-1 receptor agonists cause contraction of radial muscle. radial muscle of iris, causing mydriasis. They dilate pupil. Propulsive smooth muscle of gastrointestinal tract. Alpha-1 adrenoceptor activity inhibit muscle contraction. In the smooth muscle of bladder, trigon and bladder neck is innervated by sympathetic neurons, and noradrenaline via alpha-1 adrenoceptor cause contraction of trigon and bladder neck. Noradrenaline released from postganglionic sympathetic neuron innervating blood vessel smooth muscle cause vasoconstriction by activating alpha-1 adrenoceptors. Pilomotor muscle are responsible for the attitude of hair shaft. They receive only sympathetic innervation. Noradrenaline evokes muscle contraction and the hair shaft stand up. In fairy animal, the pilomotor muscle play an important role in thermoregulation. In seminal vesicle and vas deferens, they receive sympathetic innervation and noradrenaline evoke contraction of a smooth muscle. It's mediated via alpha-1 adrenoceptor. Example of location and effect mediated by alpha-2 adrenoceptors. Alpha-2 adrenoceptors are mainly found on the nerve terminal of adrenergic neurons and act as a feedback controls of noradrenaline release. In addition, presynaptic alpha-2 adrenoceptors are also found on other neurons, including some cholinergic neurons. For example, cholinergic neurons in the GI tract. Circulating adrenaline would activate this receptor and reduce acetylcholine release. The brainstem vasomotor center governs the tonic discharge of sympathetic neurons innervating blood vessels, and the resultant vascular muscle tone is one of the factors responsible for the maintenance of blood pressure. Alpha-2 adrenoceptor agonists will inhibit sympathetic outflow. Alpha adrenoceptor also found on platelet and pancreatic beta cells. Adrenaline by activating alpha-2 adrenoceptor will decrease and reduce insulin secretion. Example of location and effect mediated by beta-1 adrenoceptor. Sympathetic neurons innervate all regions of the heart. and noradrenaline effect is mediated by beta-1 adrenoreceptors. Noradrenaline increases the discharge rate of SA node and the heart rate rises, increased firing rate. Noradrenaline also increases conduction through the AV node and its associated Purkinje fiber. Agonists at beta-1 adrenoreceptor reduce refractory period and increase automaticity. The ventricular myocardium performs most of the cardiac pumping work. Beta-1 adrenoreceptor activation increases the force of contraction. Beta-1 adrenoreceptor also found on the gastrointestinal tract and cause relaxation of smooth muscle. Remember, on GI tract, parasympathetic activity is dominant. The juxtaglomerular cell are a specialized cell in the afferent arterioles in the kidney. The juxtaglomerular apparatus is important in controlling blood flow to the nephron and the glomerular filtration rate. Activation of beta-1 adrenoreceptor increase renin release from specialized granular cells which contain renin. Therefore, beta-1 activation will increase renin release. As you know from your physiology lecture, renin will activate renin-angiotensin-aldosterone system, causing vasoconstriction and fluid retention. Example of location and effect of an effect mediated by beta-2 adrenoreceptors. On the respiratory smooth muscle, noradrenaline released from sympathetic neurons evoke relaxation of smooth muscle. Bronchodilation is mediated via beta-2 adrenoreceptor. Beta-2 adrenoreceptors are found on uterus, mediating relaxation of smooth muscle. Skeletal muscle are not innervated by sympathetic neurons, but beta-2 adrenoreceptors exist on the skeletal muscle. These beta adrenoreceptors are activated by circulating adrenaline in the blood, resulting in tremor and breakdown of glycogenolysis. Clenbuterol is a beta-2 agonist used by sportsmen to improve muscle performance. Beta-2 adrenoreceptor also found on vascular smooth muscle. The smooth muscle of blood vessel is arranged circularly around the lumen. Noradrenaline released from sympathetic neurons only activate alpha-1 adrenoreceptor and cause vasoconstriction. Beta-2 adrenoreceptors are activated by circulating adrenaline. Adrenaline, by activating beta-2 adrenoreceptor, will cause vasodilatation. Adrenaline activates both alpha-1 and beta-2 adrenoreceptors. Normally, alpha-1 adrenoreceptor action is dominant. Therefore, generally speaking, adrenaline causes vasoconstriction. But selective beta-2 agonists can cause vasodilatation. Adrenoreceptor agonists have wide range of clinical application. I am going to briefly explain some of their clinical use. Anaphylactic shock is due to vast release of histamine. Adrenaline is the saving drug in the treatment of anaphylactic shock. Adrenaline is given to evoke vasoconstriction, bronchodilation, and reducing the capillary permeability. Remember, adrenaline shows relatively little receptor selectivity. During shock, blood flow to the skin is compromised. Therefore, adrenaline must be given by either intramuscular injection or, in the severe cases, by a slow IV infusion. Notice that adrenaline can increase heart automaticity. Therefore, it can cause cardiac dysrhythmia. Having said that, high dose of adrenaline might be used in cardiac arrest. Isoproterenol temporarily is used in the treatment of heart block. Long-term treatment need artificial pacemaker. In cardiogenic shock, which is result from inadequate blood flow due to dysfunction of ventricular of the heart, selective beta-1 agonists, including dobutamine, increase cardiac contractility with limited increase in heart rate. Dopamine has mixed vasodilator and vasoconstrictor action. Dopamine activates dopamine receptor on renal vessels, on renal blood vessel. Dopamine receptor is associated with adrenal cyclase. Increase in cyclic AMP level cause vasodilation of renal vessels. Therefore, dopamine selectively dilate renal vessels. Dopamine also activates alpha-1 adrenoreceptor on the other vessels and raises blood pressure. Long-term treatment of shock by adrenaline results in renal failure due to renal vasoconstriction. In this case, dopamine would be substituted for adrenaline to avoid renal failure. At higher concentration, beta 1 activity of dopamine also can be seen. In treatment of cardiogenic shock, a combination of dobutamine and renal dose of dopamine is used. Before 1960 decade, adrenaline was used for treatment of asthma. Adrenaline via beta-2 adrenoreceptor causes bronchodilation. However, it simultaneously increases heart rate and blood pressure. During 1960, isoproterenol was introduced as an anti-asthmatic drug. It is both beta-1 and beta-2 agonist. Isoproterenol reduces airway resistance in bronchial asthma. However, it causes tachycardia, ectopic beat, and dangerous dysrhythmia. Towards the end of 1960, salbutamol was developed as a selective beta-2 adrenoreceptor agonist. Salbutamol relaxes bronchial smooth muscle at doses that have little or no cardiac stimulatory activity. Selective beta-2 agonists like salbutamol, terbutaline, salmeterol are drugs of choice for treatment of asthma. They have longer duration of action than isoproterenol and especially to minimize the side effects, they are given by inhalation. Drops containing oxymetazoline, ephedrine, or phenylephrine are used for short term of nasal congestion. They call nasal decongestion. They constrict nasal blood vessels and reduce nasal congestion. Long-term treatment should be avoided. Selective beta-2 adrenoreceptor agonists like salbutamol, terbutaline, or ritodrine can be used for inhibition of premature labor. Adrenaline or epinephrine is included in the formulation of some local anesthetic for injection. By causing vasoconstriction at injection site, adrenaline prolongs the local anesthetic action. Alpha-2 agonists such as clonidine have been used for management of hypertension, menopausal flushing, lowering intraocular pressure, possibly by reducing the production of aqueous humor, and as a prophylaxis for treatment of migraine. This figure represents the cardiovascular effect of intravenous administration of phenylephrine, adrenaline, and isoproterenol. Phenylephrine, a selective alpha-1 agonist, increases both systolic and diastolic pressure. Here is systolic pressure, this is the diastolic pressure, and heart rate also mentioned here. So we got the systolic, diastolic pressure, and the heart rate, as you can see. Injection of phenylephrine increase both systolic and diastolic blood pressure, as you can see. As the blood pressure rises, it activates baroreceptors in aortic arch and result in reflex bradycardia. As you see, the heart rate is reduced. Adrenaline is a mixed alpha and beta agonist. It increases systolic blood pressure more than diastolic blood pressure because it also activates beta-2 adrenoreceptor on blood vessels and cause some degree of vasodilatation. Therefore, despite increase in heart rate, the mean blood pressure is reduced in comparison with phenylephrine. Isoproterenol is a selective beta agonist. By activating beta-1 adrenoreceptor, it strongly increases heart rate. However, blood pressure, especially diastolic blood pressure, is reduced because it only activates beta-2 adrenoreceptor on blood vessel and has no effect on alpha adrenoreceptor.